We'll move on to 7.4, consideration of presentation on Lake County Behavioral Health Services, Mental Health Services Act, annual update for fiscal year 25-26, and approval of modifications to the three-year plan spanning 2023 to 2024, 24 to 25, and 25 to 26, and B, resolution adopting the annual fiscal year 25-26 update to the three-year Lake County Mental Health Services Act program and expenditure plan. And we have Scott and Amber.
Morning. My name is Scott Abbott. I am the program manager for the Mental Health Services Act and Housing. I have a presentation that if I could be upgraded to panel member.
All right.
Remember which button to push for the presentation. Okay. Good.
There you go.
Sorry about the delay there. As you probably are aware, or at least remember, we have what is called Mental Health Services Act, and that is oversees mental health services for the last 15 years or so. And part of that is every year we do either a 3-year plan or an update to that 3-year plan. And this is the last year of the last 3-year plan that I need to present to you for your approval. Okay, I don't like it when it does that, but okay. Just real quick, this is a slideshow that's a briefer version of the one that's in your packet. The one in your packet is kind of long. I apologize for that, but this is much shorter. So I'm going to try and get through as quickly as possible for the sake of time. But essentially, we'll be looking at what exactly the Mental Health Services Act is as a refresher. We'll talk about the community planning process that was done for the last 6 months for this update. And the results of that, and the modifications to the current 3-year plan. And then I'd just like to spend a little bit of time talking about the Behavioral Health Services Act, which is from Proposition 1 last year, that has significantly altered the Mental Health Services Act. And it will be impacting our community in coming years. And also just have a little bit of data just from behavioral health that I'd like to share. Excuse me. Mental Health Services Act, is it, just real quick, it's an act that, like I said, was approved by Proposition 63 in 2004. It represents a 1% tax on anyone that's making over $1 million. And that is distributed to the counties based on their population size. And there are specific components and requirements to go within that act. One of the main ones is the slide before you, which kind of is the breakdown of the funding that is supposed to take place. 76% of that funding is for community services and supports, and about half of that funding is for this full service partnership program, which is probably our most significant program that we have in the mental health department, which is designed for those who are most in need due to their mental health and are at a risk of either incarceration, institutionalization, or homelessness due to their mental health. It also funds other programs such as our peer support centers, and then we also have prevention and early education, which is another 19%, and then innovation, which is 5%. The last two, workforce education and training, and capital facilities and technological needs, both of those actually come from the top ones, CSS, where we have the option to be able to divert 20% of our CSS funding for those two categories. Purpose of the annual update, as I mentioned earlier, by law, we have to do an update of each year. MHSA is a very grassroots-driven process. The proposition was very grassroots and that it started, and it's the idea that the community has the input on what services are to be provided and what the priorities are for services for MHSA. Hence the community planning process, which goes into that. Just real quickly, there's also contained in the update is a PEI evaluation reporting, which is just a requirement. They want the state as required a separate report just for prevention, early education processes and programs that have been happening in our county. So that is also a part of it. MHSA background overview. It can also be found further information on our website at this particular web address. This slide right here just represents the programming that we have that's based on from our MHSA funding. Just real quickly, I won't go through all of them, but our crisis access continuum includes being able to support our mobile crisis services that we are doing. I mentioned our full service partnership, which I mentioned is our probably our largest program. Also trauma focused co-occurring disorder screening and treatment. Our peer support recovery centers, which is also a very, very big program that we have, as you are probably familiar with the four different peer support centers we have around the lake: the Big Oak Center, Lavos, just drawing a blank here.
Circle of Native Minds.
Circle of Native Minds, and Harbor on the Main. Also, we have just within our prevention early education programs, we do a lot of outreach within the schools, doing presentations, doing mental health first aid, suicide prevention, doing a vast amount of that. Our goal is to be able to give every 10th grader in the county mental health first aid, so that they can be able to recognize mental health issues And it also helps kind of reduce the stigma that goes along with mental health issues. Innovation reports, we currently do not have innovation project at the moment. And CAF Facilities and Tech Needs has gone to our electronic health record. And we do have some funding set aside to update our South Shore Clear Lake Clinic. Just real quick here, this is demographic or kind of a display of how many folks we are serving within MHSA and their makeup. So for the CSS programs, 586. For the PEI programs, because we're going out, like I said, touching schools, doing events and other things like that, we end up touching a lot more folks. The CSS programs are more of the treatment-centered type of approaches.
Supervisor Spatier?
Can I pause you on back one? So I've had a recent discussion with behavioral health about this, and I just kind of wanted to highlight this. And it's one that I've noticed in some other reporting for the race ethnicity, 48% or 46% unreported or unknown. I would like to see that number decreased to understand who exactly we are serving, knowing that when we do our community health needs assessment, which includes behavioral health to a certain degree, we recognize that certain groups are much more lower on the status of health and mental health. And it's hard for me to continue to understand if we are serving the easiest to serve or the neediest that need to be served. I know that there's efforts being made, but it's all very anecdotal and rhetorical rather than shown through the data. And so if there's ways to use the INN dollars that right now is not being funded or does not have a project in order to make greater attempts to capture that data, that would be greatly appreciated, because there's times where I feel flying a little bit blind as to exactly who it is that we are serving. I know we're serving, but I don't know who it is that we are serving. Just wanted to mention that.
Yeah, I appreciate that. Often when the data is collected, it's collected from the clients themselves, and many of them do not report, what their makeup is. They just choose not to. But it's something also that we recognize that we need to do better at. Probably innovation dollars aren't necessary for that. I think it's just, just more increased effort to do that.
Supervisor
That
Peister?
was my point too, is that's self-reported. So it's difficult to force people to report. We can't. But having more welcoming environments, a place that feels more safe, we work on that, then maybe people will feel more compelled to report something other than unknown.
I totally agree. And we'll talk, there's a little bit more the same data at the end of this presentation. The slide I just showed was just mostly MHSA. Also the slide just entirely behavioral health, which gives a little bit more information. I do want to report on a little bit of outcomes. These are the outcomes for our full service partnership program, which I mentioned is our largest program. And these next three slides show that, this program really makes a difference in people's lives. And this one shows that due to the full service partnership program, the interventions that it does, it increases the number of partners living in traditional residential settings and reduces the number of partners in emergency shelters, psychiatric hospitals, and long-term care. So that's one of the main goals, is to get people in recovery, being able to live in the community. as opposed to being incarcerated or institutionalized or homeless. This next particular one shows emergency events, which essentially are trips to the emergency room. That Full Service Partnership has also reduced those for the folks that are in the program. And this last slide shows the number of arrests that have been reduced. There wasn't a lot arrested to begin with in this, but it did go from 3 to 0. As I mentioned, the community assessment, we did that for the first 6 months of this update, and I want to go through the findings of that community assessment. The data was gathered mostly in two different ways. One from a community survey that we did right at the beginning of the year. We got 49 respondents, and then we did 2 community meetings at the end of January and the end of March. And from that we got both qualitative and quantitative data. So some of the findings that we got from that, perceptions about Lake County Behavioral Services meeting the community's needs were mixed. Respondents generally felt that peer support services, which are the peer support centers, meet the needs of the community they serve, while prevention and early intervention services do not. And I suspect that for that last one, about the prevention and early intervention services, that many people aren't aware of the prevention and early intervention services that exist. For example, going into all the different schools. So that kind of tells me a little bit more. We need to kind of get the word out of what we're doing to the community. Access to services. Most participants knew how to access behavioral health services. However, participants generally felt it was not easy to get an appointment. And so this is an area that we are addressing as an entire department to improve. Experience with services have been positive perceptions, feeling that we are helping. Here are some strengths that were identified for the department as a whole through this survey. Welcoming, approachable, available. We do some outreach, we're responsive, and again, the effective peer model, which people seem to greatly appreciate. Some identified gaps that the community assessment survey found is suicide prevention. Felt that there needs to be more done. Substance use, follow-up support. For example, when people do graduate or from programs, having some follow-up support with that. Services for mild to moderate needs, and again, prevention, as I mentioned. These are the folks that are felt we could do better at. Young children and teens, older adults, unhoused individuals, historically marginalized groups, which would include minority groups such as the Native American community or LGBTQ. So this provides some opportunities. We have we identified that ways our department can do better, and so all these are kind of ingrained within the different programs that I described earlier. And so, the results of this survey are being used to improve within each of the programs, as opposed to creating new programs or altering programs or anything. These will be integrated within existing programs to improve quality. Again, here's a listing of different services that we have or provided by MHSA. And because this is the last year of a 3-year plan, and the next year BHSA starts with a whole new set of conditions, we didn't want to make a lot of modifications for this last year of this plan, as we're going to be starting new stuff, brand new stuff, next year. And so, as far as programming. And so, one thing we're looking at doing is folding in the trauma-focused co-occurring disorder and screening treatment program, folding that into the full service partnership program, because essentially that's exactly what's happening right now anyway. We're not having a lot of responses as the trauma-focused program occurring just independently, but it has been existing within other programs, and so we want to emphasize it within our full service partnership program. The other change is innovation, where we have an opportunity from, and I'll talk about that in a minute, but we got an opportunity from Cal MHSA for them to create a dashboard. We call it dashboard program. I don't know.
Dashboard.
Dashboards for our EHR to be able to quickly and more efficiently read the data that exists within electronic records, health records. And this is exactly just what it is said, sorry. And again, this is kind of reflects what I talked about here, of the modifications that we'll be making kind of within our programs to address some of the findings that were in our surveying and meeting data that we collected. Some of these things we've already implemented. For example, enhancing our presence on social media. We have Megan, who is here, and she is our social media guru. We try and get all of our announcements and so forth on social media. I don't want to go through all these just for sake of time, but this is the idea of what we've learned from the community assessment of integrating it within existing services. I don't know if anyone has any questions about this.
No,
I think it's kind of self-explanatory, but let me know.
We can continue on.
This is the fiscal part. I kind of want to emphasize this a little bit because just for transparency of how MHSA works. As I mentioned, it's a 1% tax on anything made over $1 million. The funding is distributed to all 58 counties based on population size. Due to the 1% tax, just the nature of it, funding kind of ebbs and flows. Sometimes there'll be a lot, sometimes there won't be, depending on how the economy is doing. And so, as you can, the estimated statewide MHSA funding in that category, you can see that it does vary, by around $1 billion for the state. And so, that affects the funding that we receive. We receive I think it's 0.18% of the funding due to our population size. And so from that, you can see we kind of estimate for 25, 26, and 26, 27 based on statewide revenues that they're expecting, what we should be expecting. Now, the good thing about MHSA, something that I've greatly appreciated, is because of the kind of volatility of the funding, We do have 5 years to spend any given year. And so that allows for carryover of funding. And so, because of that, we can be a little more even in our approach as far as funding and spending. Because we have 5 years to spend an amount of money, we can kind of,
One second. If we're having conversations, if we could step out, we're almost finished with this presentation. I know we're behind a little bit, but I hear a lot of talking, and I think it's been distracting some of the other folks. So go ahead and continue, please.
Sure. Anyway, so we can spend more kind of in the middle. With the carryover on lean years and excess on not lean years. So this is our overall budget, which includes unspent funds carrying over into these categories. We never spend $8.4 million, but it's the funding that currently and will exist for MHSA. What this is about is our annual revenue and expense report, which describes where the funding is spent. That's on our webpage, and so if you are curious, or if anyone is curious to see how our funding is spent, this gives a nice description based on breaking it down by CSS, PEI, innovation, and so forth. Any questions on that before I move on? Okay. I just want to, like I said, just quickly touch on the Behavioral Health Services Act. That was part of Proposition 1 last year. I just want to kind of cover this because it's something that we will be bringing back to the board to talk about. So it's kind of a preview of what we'll be starting to work on. Because, again, well, let me just describe the Behavioral Services Act. Behavioral Services Act, what it did is it renames MHSA to BHSA, which means that it expanded to include substance abuse services besides just mental health services. It significantly revises the distribution of funding and prioritize housing, and I'll show you that slide in a minute. It establishes expanded oversight and accountability measures, including an integrated plan for mental health and substance use services. So it's aimed at trying to be more transparent in how the programming works. The other component of it, which I just kind of skipped over, was part of Proposition 1 was Behavioral Health Infrastructure Bond Act. That was the one that raised $6.4 billion in bonds, and some of that funding will be used in Lake County, which is great. This is a slide I really like because it really kind of sums up the differences between MHSA and BHSA as far as funding allocations. The pie chart shows that the state is going to keep an extra 5% in their distribution. And then you can see the current modifications which I previously described of CSS, PEI, and innovation, and so forth, and how that transfers down to the new categories, which are essentially they're looking at for BHSA 35% for FSP, and that's pretty close to what we have right now. We have right now as 39%. FSP, a really significant portion of that funding goes for our housing that we pay for housing assistance, including supportive permanent housing and temporary housing across the county. And so, like I said, that essentially kind of remains the same. What is very different, though, is that PEI, innovation, and everything else has been kind of scrunched down into the 35% of which they call behavioral health services and supports. So and they did that to make room for the other 30% for housing, which as you know, California is looking to address homelessness, and the governor has thought that MHSA would be a good way to do that. But unfortunately, that also would mean the reduction of other services that we currently do, particularly our peer support centers. However, there is an exemption that small counties can apply for populations under 200,000, where that 30% housing intervention is not done for this next 3-year plan. This category is also going to be included for larger counties for the next 3-year plan, but smaller counties can take advantage of it earlier. And so that's something that we will want to consider doing, particularly because we currently address homelessness in our current plans, and our behavioral health department is very, very involved in addressing homelessness right now. And but again, this will have to come from the community. We need to get the community involved to help guide this decision.
Scott, if we can wrap up.
I'm sorry.
We are way behind now. Yeah.
Okay. This is just the hot timeline. Thank you for letting me know. More information is also involved on here. Just real quickly, there's 2 slides worth of data of overall of the folks that we serve. This first one is the penetration rates of how many folks that we serve within the community. And this last one is kind of what we touched on a little bit earlier on the demographics, racial backgrounds of those that we serve. As you can see, threw me off for a second, 78,000. Well, I figured out that meant that was duplicated folks in there as well. So that's why that number is bigger than our 65,000 that we have. Okay, that's it.
All right.
Sorry.
Questions from the board? Supervisor Sabatier?
Can we get a copy of that slide? Because you have other slides that aren't in the one that was
Oh, it's not in the
provided. Yeah,
Yeah,
please.
we can do that.
All right, I'll open it up for public comment. Any on Zoom?
No.
All right, so I'll bring it back to the board for action.
Mr. Chair, it looks like 2 parts to this. Do it separately.
Yes, so the first part is just a presentation, I believe, unless,
I thought it requested approval of modifications
Yeah.
Yes.
to the 3-year.
so that would be by motion.
Okay. So, Mr. Chair, I'll move to accept the presentation and approve modifications to the Mental Health Services Act Annual Update Plan for fiscal year 25-26.
Second.
So I have a motion and a second. All in favor?
Aye.
Any opposed? That motion carries 5-0.
And second, I would offer the resolution adopting the annual fiscal year 25-26 update to the 3-year Lake County Mental Health Services Act program and expenditure plan.
Resolution has been offered.
Supervisor Owen,
Aye.
Sabatier,
Aye.
Asmussen,
Aye.
Pyska,
Yes.
and Crandall.
Yes.
Thank you.
All right, I think that covers them all. Thank you very much.
Thank you very much.
Presentation.